Good morning, everyone. Let me start with apologies, which is that I do not speak the Spanish language. And I'm very sorry, so I will be talking in English. I will try to talk slowly so that those who do understand English can follow me. And I hope some others will have the aid of the translators. So thank you very much for this honorable invitation. And let me start by saying that I'm highly impressed, even though I don't understand Spanish, but I did get a grasp of everything that you've done. So I want to start with compliments for much more activities that you have been doing in the domain of EPAs than I had realized at all. What I will do now is give you a very general background of why did we ever start with working with EPAs, and how does it relate to competency-based medical education. So my background, my name is Olle and Cate. My background is I'm a professor of medical education, working at the University of Utrecht, University Medical Center Utrecht. My talk will be basically in 4 sections. I will say a little bit about competency-based medical education and the frameworks that have been created in the past decades. Then I'll go more in detail on Entrustable Professional Activities, or what they exactly are. And then linked to that concept is entrustment decision making. So I want to spend a little time to talk about that too. And maybe end with how EPAs can cross boundaries. And I'll explain that when we get to that. So competency-based medical education was first mentioned in 1978 in an important document for the WHO by McGeoghegan and his colleagues. And they actually explained competency-based medical education in a way that we would still use it now. But for some reason, CBME, or competency-based medical education, did not get much attention in the 1980s and the 1990s. Until, and I would say probably mostly in Canada, where it started, people felt unsatisfied with their current education and started reviving that concept of competency-based education. And they created a model called the CanMEDS model that you see in the left bottom of the slide. But there were also other frameworks. The United States started quickly after with a framework that has been called the Outcome Project, or the ACGME framework. And the United Kingdom started with their own frameworks, and some other countries started doing things. And why was that? Actually, it was originated from postgraduate training, so medical specialty training. There was a dissatisfaction with the quality of training and with the quality of care. The quality of training models and supervision and patient safety were critical issues. There were some incidents in the 1980s and 1990s where trainees were involved, residents mostly, and things didn't go right, and people started thinking maybe we should rethink postgraduate training. And maybe just for a minute, I can explain you what happened. So if we think 1 century ago, in Western medical schools, most of the people would go to practice after medical school. But then specialties started arising. And when a person would like to be a specialist, what the schools actually said is, why don't you just spend some time there in that clinic, and if you have spent like 2 years or 3 years or 4 years, we will just call you a specialist. We'll give you a diploma, and then you can call yourself a specialist. At that time, we didn't start with examinations, and there was little control over it. Now, when the Canadians started thinking of postgraduate training, they started thinking, we are not satisfied with people just walking around in clinics and then getting a diploma if we don't know, if we cannot secure that they can actually do the things that we expect them to do. So we need standards, and we need to make sure that people meet those standards. So the essence of competency-based medical education is that there is a goal of securing safer and higher quality practice by improved training and assessment. And by creating those frameworks, it is actually defining a physician with a broader and better and more valid description of what a physician is. More detailed, and people started thinking, if you, and the Canadians actually did a broad investigation in different parts of society, asking people, what do you expect of a medical specialist? What does a medical specialist look like? What is important? And that actually led to a better description and then a competency framework. Then critical is that the competency-based medical education is based on their outcomes and not on the process. So it's not enough to just to say, if you have practiced for 3 or 4 years, you will be ready for independent practice. No, people would say, we really want to look what you have accomplished in those years. And actually, if you would say, if you have not accomplished everything that we think you should, maybe we should not graduate you. So it's really based on outcomes rather than on the process. So it's a move from assuming competence to assessing competence, with the aim of licensing physicians or registering specialists only when they meet standards. That's based on competence and not just on the time in training. Let me just show you, give you an example of something that happened in the Netherlands. This is data from radiology training. Our radiologists from 2005 on all take one broad examination on all topics for radiology that are important. That examination is broad, it's national for all residents in the country. It's administered twice a year, and it is only summative. It's only formative, not summative. That means that everybody has to take that exam, but they cannot fail the exam. They always would pass because it's just a formative measure, but it is mandatory to take that exam. So what you can see in these data here, that the same exam taken by first year, second year, third year, fourth year, fifth year residents reflects that the first year residents do not do very well, but they increase in their knowledge exactly in a shape that you would expect. So at the fifth year, most of the residents actually meet the standards that people would expect. But then, since it was not a summative test, if you don't pass the test, you could still be a radiologist. And now the radiologist people said, we wanted to make more competency-based. We really want that everybody meets that standard. So they draw a line and said, actually, if you look at it, it's not a very high line. The third year residency residents in training already, many of them already meet that. But what is critical is we have a group of residents in the fifth year that do not meet that standard yet. And we don't want to continue graduating those people. If they need more time, they must have more time, because now our outcomes are more important than the time in training. So that's an example of how competency-based education is operationalized. So competency frameworks were made very elaborate, and they were used worldwide. The CanMEDS framework has been exported to many countries. My own country, the Netherlands in Europe, actually adopted the CanMEDS framework. And so actually many jurisdictions are happy with the frameworks. But if you think of it, and what we see happening over time is that the frameworks, when they get more and new additions, get more and more detailed. And the competencies, as they are described, are sometimes rather abstract and general. And the clinical teachers are now forced to evaluate individual learners, trainees in their workplace with that competency framework, and they sometimes find that difficult to do. They look at a trainee, and then they have these competencies, and they have to guess whether these persons meet those standards or not yet. They find that very difficult. And many of these things you cannot take in a written test. We actually want to see people, are they doing the work the way they should? So that's difficult to do that. And teaching, the clinical teachers start struggling with that assessment. And if you look at the literature, that's the reason why the literature also shows some people who are critical about competency-based education. They say it is sometimes difficult, it's theoretical, it's not practical. And if you think of it, it's actually the natural how it works. So in Canada, when this would be like in the 1980s or 90s, they would say the doctor, that is not enough. We need to break up the doctor because we have to describe it well. Now, this was the start of the CanMEDS framework. They started with 7 roles, and the roles are very intuitive. We all realize that the doctor should have medical expertise in their minds, of course, but they should be a very good collaborator, because medical care is done in collaboration with other people, with nursing, with other people. Communication is very important. They should be a communicator. They should be a leader, a manager. And they should be a health advocate. They should be a scholar. They should understand how they find knowledge. They should be a professional. So that should be all domains that we should assess in those persons. We should make sure that all those meet those criteria. But if you say communicator, as take one example, that may not be enough. That's still a very abstract term. We have to operationalize that. Maybe we should split that up again. So we should think of communication with nursing is different than communication with families of the patients, or with the patients themselves, or communication with our colleagues, or with trainees. And if you just take patients, that may still not be granular enough, because if you look at how doctors interact with patients, they could have a consultation. At another moment, they should have to break bad news, or they have to explain medication, or they have to communicate with small children, but also maybe with elderly people. And maybe we should all evaluate that they are able to do that. And if you think of it, we get more and more detailed. And here's where we get lost. I mean, we can't see the trees through the forest anymore. And if you look at the most recent framework of CanMEDS that was created in 2015, it now has 739 components. It's a very extensive document. And if you read through it, you will probably agree it's a very good description of a specialist. And it's not even specialty specific. It holds across all the specialties. But there's 161 key concepts and 28 key competencies and 116 enabling competencies, and 434 milestones have been added now. And you read it and you get really tears in your eyes, because you think this is such a nice document. It really describes it well. And next week, but you're very motivated. Next month, you read it again. And then you put it in your drawer. You hope you'll read it again once. And then you go out and then you start evaluating your trainees, but you can't remember that all. So there is maybe something in that criticism of, are we getting too analytic? Or can we really do that? And these descriptions are sometimes somewhat abstract. So here we thought maybe we should do something different. Maybe think of, approach our education from a different angle. And that angle we called Entrustable Professional Activities. And we just think of, what do doctors actually do when they start their practice on Monday morning after the weekend on 8 o'clock? What exactly do they do? And how can we train them to do that work? So back to the basic question is, first ask the question, what is healthcare work? What contains that? What are those units of practice? And then, what qualities must healthcare workers have to be trusted to do that? So just a brief summary of what an EPA is, the definition, and I noticed that you have translated the definition well in Spanish. Units of professional practice, and think of it as a task that must be done. Those units that can be fully entrusted to a trainee once he or she has demonstrated the necessary competence to execute this activity without supervision. That's the definition. And if you think of it more specifically, they are really parts of essential professional work in a given context. Sometimes you would have to say, you are allowed, we will trust you to do this now in this context. Maybe a different context would require again our evaluation whether you could do that. But so essential professional work in a given context, executable within a time frame. So an EPA should have a beginning and an end. It should acquire adequate knowledge, skills, and attitudes, generally acquired through training. It should be observable and measurable. I should be able to say, this is well done, and the outcome is okay. It should usually they are confined to qualified personnel only. So you would not want somebody else to do a medical EPA because that's only confined to those people who have shown that they can actually do that. And it should reflect one or more of the competencies that you already have defined that you find important. So I'm not saying we should move away from even ChenMeds, because the framework of 7 domains or 7 roles is a beautiful framework. And we can use that, but we should combine that with what are the activities that need to be done. So the purpose of using EPAs is to ground those competencies into what happens in daily practice, to increase the transparency about the objectives. We want teachers and students and trainees to know exactly what am I being trained for, what must I be trusted to do if I'm done with training. And so increase that transparency and to formalize entrustment decisions. And that has implications for curricula in the workplace, for assessment in the workplace, for undergraduate education, for postgraduate education, but also for CME, for continuing medical education. And it also would be applicable to various specialties and professions in healthcare. We tend to think about medical education all the time, but I can tell you there's now many other health professions that are really thinking of using EPAs in nursing, physical therapy, in dentistry. I just went last week, I was on a conference for pharmacy educators. They are very determined to start working with EPAs. So people keep back on the question, what is an EPA and what is a competency, and what exactly is the difference between the two? So you have to remember that EPAs are no less and no more than thus the units of work, the tasks that must be done. So here's the environment. If you would be the environment hospital, I come to the hospital and I'm looking around, what are the tasks that must be done, and give me those tasks and I'll do it. The competencies describe me. I can only do that if I have the right competencies, and you would trust me to do that. So basically, I possess competencies, and you all possess certain competencies, but you never possess an EPA, because an EPA is the work that must be done. That's on the right side, the physician work list, or you could think of a personnel advertisement. If you would hire a person, you would have to list, what are you hiring that person for? And there's many things that must be done. And so, and the left side, that are the competencies. Just keep those distinctions in mind. So competencies are person descriptors, EPAs are work descriptors. The person descriptors are knowledge, skills, attitudes, values, abilities, all those elements that describe how how well a person is trained to do things. The EPAs are the essential things that must be done. This patient must be discharged, and we need to have a discharge. Somebody must be able to do that, make sure that the patient is transferred well, or this patient needs counseling. And we need maybe a specialist or somebody who can counsel that patient on that particular question or problem. Here's a family meeting, so the family is coming and they need to be informed about their maybe elderly patient or maybe a baby. They need, we have to talk with the family, and the family is sometimes very critical, so you need specific skills to be able to do that. Here's a treatment plan. Here's a complex patient with multimorbidity. It's not easy to make that treatment plan. We need a person who can do that well. Here's a patient that must be resuscitated. Here's code red or something. We need a person who is in the house that can actually resuscitate that patient. So those are all activities, and that must be done, and that activity requires a profile, and we're looking for the person who has that profile that exactly fits it. And if we don't have those persons with those profiles, we better get those persons trained to do that. So our task as educators to shape those people to have the competencies to be able to do that work, those tasks. So if you look at training in healthcare, and you could actually look at the training from two dimensions. One is the dimension of competencies, and of course you want to make sure that people have those qualities, they have knowledge, skills, attitudes, and all those things. But here is the task that must be done. Now think of your own practice. Think of any task in your environment that must be done, and think of the competencies that are required to do that task. And almost always you'll find that there's more than one domain of competence that works together, that is integrated into that activity. See, if you take a simple example as history taking. So history, of course, you must be able to communicate with the patient, and that also requires professionalism. But if you don't know what next question to ask, you don't have that expertise, you cannot take a history. And at the end of the day, we want to make sure that you can do a history. And of course, that all those things come together. Some people will take a history and do first history and then a physical examination. Somebody else would, another clinician, would actually combine physical examination and history taking, would say, well, I'll do the physical examination. Hey, I have a finding. So that adds to my history taking. And they integrate all these things. But for one thing, you want to make sure that if you have a trainee trained well, they must be able to take the history taking with all the competencies that are required. And think of anything else in your practice, you will see that competencies are combined. So they integrate. And that's really the concept of working with EPAs, the integration of those competencies. And if you assess learners, you better focus on those EPAs than the assessment on individual competency domains. At the end of the day, you might think that people are, and you're very often a little bit unsure whether they are a good communicator or not. But basically, we just want to make sure that they can deal with patients, or they can consult with a colleague who's difficult, because that's difficult communication skill. With some colleagues are easier to communicate than others. So basically, you want the EPAs as a focus of assessment. And in that sense, EPAs are not so much an analytic framework, but we call that a synthetic framework, that actually those competencies come together in those EPAs. Now, we talk about unsupervised and supervised practice, and what actually is that? Maybe we should talk about what we define as competent. So competence, if you would say, an easy and very practical definition is when a professional activity is mastered at some threshold level that permits trust to act unsupervised. Now think of it as a threshold. So if you think of a person developing, there's a development that grows and grows and grows, and some people get better and better all the time. But there's this moment, if you are in training, there must be a moment that we say, now you are ready to work by yourself. And it does not mean that there's no progression afterwards. There will be progression afterwards, but there must be this threshold level that we say, now we actually determined altogether, our team of educators will say, you are ready to work unsupervised. And that can hold for the whole training, you are ready to graduate, or it could hold for a single EPA. You could say, now, this EPA, you are good enough, and we can now trust you to do it by yourself. And then you could say, so competent, if you define that as competent, then competence is only a stage in a continuum. You may not be the master yet, and it may take more years to become a master, but you are competent enough to work unsupervised. And that is a critical aspect of working with EPAs. If you think of growth of competence over time, it very often looks like this shape, as you have seen with the radiology residents, but it's very often, it does look like this. And if you have a framework of developmental stages, there's a very well-known framework, starts with the lowest stage would be the novice stage, and then advanced stage, a competent stage, proficient, and expert stage. That was proposed by two people, both were brothers actually, the Dreyfus brothers in the United States in the 1980s. That framework has been used in the United States also for medical education. And the interesting thing is the word competence is right in the middle of that framework. And we could actually say, this is the definition of our training period. Our training, we are training people to be able to work unsupervised. So here's that critical moment that you would say to a learner, you are ready for unsupervised practice. Now, if you think of the same framework, but you think of this for one EPA, and an EPA could be difficult or easy, but there could be another EPA that is actually easier than this one. So logically, you would be at an earlier stage at a higher level. And maybe you could be trusted to work unsupervised at a different moment. Here's an EPA that you don't even start practicing until the second year of that training. Or here's an EPA that is really easy. Here's an EPA that you bring something already before you go into training. But if you don't practice very much, you may not get very high. But if you draw that same line, this is the line of progression, and you would say, here's where we consider you to be competent. And now we can license you to work unsupervised. But there's different moments actually in that training period. So why should we actually say for everything that people are trained for, you are licensed at the last day of training? Why couldn't we say, we could make that difference? We could say, well, you could do this from now on because we have observed you well. We could, you may do this unsupervised already now. So this is the competency curves of one trainee. Now you could imagine that not every trainee is the same. So a trainee may be different personality, or it may be, they sometimes have different experiences before they start training, or they are trained in a different hospital or different university, different school. And those justified entrustment decisions may be at different moments for a different trainee. So their curves could look like this. So there's different moments. Here's actually in this example, it's a little bit extreme example, but you could even see that there's some EPAs that you would say you're not ready at the end of the fixed training period. You need some more training, because basically it's only after that training period that we would trust you to do that, but you need some more experience. Could be for very different reasons, because you have never seen that, or we've never had that opportunity to do that. And you could actually see there's even one EPA that we, at a certain point, we'd said to that person, you are now trusted to do that by yourself. But we now acknowledge you've never practiced that. And after a while, maybe we should lose our trust. We cannot automatically keep trusting you if you never practice. Maybe we should lose trust in you to do that. There might be loss of trust. Now, if you think of think of training, we've now make that distinction between unsupervised and supervised, but there is a more granular stage of development of supervision, you could say. And early learners who come for the first time in a clinical setting, you could say, well, you have your white coats walking over here. We notice that all the medical students have a white coat, so at least they are not a regular citizen anymore, but you may be allowed the first day of your clinical training to be present, and you may observe the activity, but you may not enact them yet. So the second level would be that whether we allow you to do something, but only if there is an expert supervisor in the room to make sure that you do that right and to give you supervision or to help you when you need help. And then the third level, we say to the trainee, now you are one critical step further. We would allow you to do this without us being present in the room, but we are available for help if you need help. Pretty quickly, actually. Maybe if we're on the hallway, just if you don't fix that well, just call for help and we'll be there to help you. Level 4 would be you're now ready to act without supervision at all. So we can't be there quickly, but we still trust you to do that. And that's basically the level that we would consider you to have to be by the end of training before you can work unsupervised. And if you progress further, if you get more and more experience, you might become a supervisor and then supervise other more junior learners. So we have labeled that with numbers 1, 2, 3, 4, 5, and level 4 would be actually ready for the end of training. And you could see here's a postgraduate program and a portfolio of a trainee for, we have a selection of 4 EPAs here. And you can see that there's different moments that people actually reach at level 4. And from then on, we actually consider them, if that would be postgraduate training, you are at a level of where you should be at the end of training, so you're a colleague of us now. Just go ahead, work unsupervised for a while, and maybe even you may raise to the level of providing supervision. So that was the general background about EPAs and how are EPAs described. If you think of an EPA, it's very often, if you analyze your practice, you can identify what an EPA is. And the full description of an EPA is that it has a title, it has a specification and limitations, because we want to make sure that if we say you're allowed to do this, that we know exactly what we're talking about, that we have specified what this is. And there might even be limitations. If you are a medical student, we will allow you to do that, but only with stable patients. What are the most relevant domains of competence? What is the required knowledge, skills, attitude, and experiences that's interesting specifically for students? They can help build their own curriculum. If they know what is expected of their background knowledge, they can start preparing for that. And then 5 would be, what are the information sources? If you describe an EPA well, we also want to make sure that we know how will you ever make that decision of unsupervised practice? What information do you need to assess and ground a summative entrustment decision? So, and then another point would be entrusting for which level of supervision. Is that level 3? In our schools, all students after graduation go to postgraduate training. So we will say to students, you are at level 3, so you need supervision, but maybe indirect supervision for everything. And in postgraduate training, we'll move to level 4. In your schools, it may be different. If you have many graduates from undergraduate education who go to unsupervised practice right away, you may want to work towards level 4 in undergraduate education. So, and 7 is an expiration date. We actually say that, well, if this is a critical EPA, we want to qualify you to do this, but if you don't practice, maybe we should have specify the expiration date. Might be 1 year or 5 years, or if you don't show that you have practiced, you may not be licensed to continue doing that. So I won't go into detail in all these examples, but here's I'll have an early and a late example of an EPA. This is an early student EPA as an example, which is called the routine checkup of the stable adult patient. You'd say to a medical student, you go there, take the vital signs like pulse, breathing, temperature, blood pressure, saturation by hand or with devices, come back to us, report, explain to the patient, but report to the caregivers. You could do that orally or in a written form in the electronic health record. And the idea of being trusted to do this means we're not going to check everything anymore. We now trust you if you're well trained, and that means, and that is the critical nature of EPA's working, is contribution to healthcare. So gradually, we have learners contribute to healthcare because we are not going to check everything that you, as long as we are sure that they can do that. So there's then the relevant domains of competence, the required experience, knowledge, skills, attitudes, source of information, level and expected moment of entrustment, and an expiration date. We've all specified that. Here's a high-level one. This is the resuscitation of the multiple trauma patient in the emergency room. Just imagine a patient coming in from a car crash or so, and here's your senior program, your 4 anesthesiology residents who should be able to do that by themselves or lead their team. So it's a very complex EPA, but it's applied in residency training for anesthesiology training. So why use EPAs? They serve clarity and flexibility. It gives clear training objectives for learners. They know much better now what they are trained for. It serves the intra-trainee variation. We're not saying that you are meeting all our expectations on the last day of training, but it could be different moments in training. It serves also inter-trainee variation because not all the trainees are the same. So it's more individualized. It's different prior knowledge, skills, learning abilities, general attitudes, and then it serves context variation because training be in one hospital is different than in a different hospital. The education mindedness of staff could make a difference. So it is EPAs serve the more flexibility and individualization of training. So if we think of entrustment decisions, it is a different approach to assessment than we have used in the past. And it's interesting to think what comes into that. So what we actually think is where people have difficulty, and if you would ask people in traditional situations, if they have to evaluate a learner, it's not easy to do that. But if you, and that was very nice of the work of Jim Crossley, says, one of the problems that we have now in evaluation in the clinical workplace is that we ask the wrong questions. We should ask the good questions, and then we can expect to get reliable answers. One example of such a question is, can I leave the operation theater? So that was nice work done in New Zealand. And it is actually the EPA approach, the supervision approach to assessment. So the most important question that the attending in residency for residents in anesthesiology has is, can I leave the operation theater? Can I leave this person alone? That's the most critical question that happens in their mind always. So why not translate that to our assessment procedure? And that gives a more reliable approach. So what you actually do here is you're not observing and only evaluating the ability of the learner, but you combine that with patient care because you're saying, is this person ready for me to leave the room? Is this person ready for unsupervised practice? So it combines the ability, right, and also the duty to act. Because if you have that license to act or the certification, then we could say, well, now you are part of our team and we can schedule you for service. This has led to what has been called entrustability scales in different forms. And those scales are different from the traditional approach. Now, the traditional approach, think of the approach that we use in the Netherlands for very often is we have a 1 to 10 scale, and we're asked to evaluate learners to say, well, is this a good learner or a very good learner, or is this an excellent learner, or is this an average learner? It's very, very difficult to make that judgment. Or you could say, well, you could use A, B, C, D, E, F, as North Americans very often do. That's also difficult. Then you could say meet expectations or exceeds or below expectations. That's also difficult. And we're moving actually to, I need to explain everything, or we can do this together, and then I can watch the learner do it. I can briefly leave the room, and I can leave until she calls, or I can leave the hospital. And if you think of it, this is the way a clinician thinks anyway, so why don't we translate that to the way we assess learners? So we have those 5 basic levels, and I don't have to run through them again because I already explained them. And you can see that as shades of decreased supervision over time, from observation, direct supervision, indirect supervision, distant supervision, and no supervision anymore. And here's that moment of summative decision of unsupervised practice. You'd say, you're still in training, but we consider you our colleague already. Those are observation only level 1. Level 2 would be direct proactive supervision. Supervisor sitting next can take over. Here's indirect reactive supervision afterwards, or distant supervision, clinical oversight. There's not someone present who is going to immediately help. Or you could be a supervisor level 5. These are the information source if you think of how to evaluate learners and what can we use as information to make those decisions. Short practice observations, case-based discussions, longitudinal practice observations. We could also involve other people, multi-sources, even nurses could say that, or product evaluation, things that people have created, we could evaluate. And then if they meet that standard, just as a fantasy, think of it this way. Think of you're giving a statement of awarded responsibility. It's like a STAR. That's the acronym. So you would say, this trainee with this name, from tomorrow, we will allow you to, for this EPA, this specification, you can do this now, but there's limitations, and this is the level of supervision. Today is the date, and we will sign that. We have used this form in one of our projects. And people first say, the clinicians first say, we can evaluate trainees, no problem. And then we said, okay, then sign this form that you would allow this person to work unsupervised. And then say, do I really have to put my signature there? Oh, that's a different story. Then I'll probably go back and look at the trainee, have another look at them, because that's critical. So that's exactly what you want with entrustment decisions, to make sure that clinicians really think by themselves, I actually trust them. And if you think of it to crossing borders, and I'm almost at the end of this talk, if we think of EPAs, and as I said, we started thinking about it in postgraduate training, but now undergraduate training starts using them, and your project is all based on undergraduate training. So what we actually say is, in undergraduate training, there's a series of EPAs that you could meet. In postgraduate training, some of them may not be necessary, so don't use them. Others are expanded and more deeply. There's new EPAs added. At the end of postgraduate training, there will be a series of EPAs. And then in practice, some of those EPAs may never be practiced because you don't use them. If I talk to our senior anesthetists, they would say, well, I never do this critical procedure anymore. I wouldn't trust myself if I don't do it under supervision. So here's where you should actually lose the license to do that. But you may also add new EPAs because there's new things that you have never been trained in, but you need in later when you, after education, you can add them still. So if you think of competency-based education, we have several stages now. This is the typical North American stage when after school you go to undergraduate bachelor degree, then undergraduate medical education, then graduate medical education and fellowship, and then unsupervised practice. And what you decrease education and increase practice over time. And what you actually want to end up is competency-based medical practice over time. And we call that working with a dynamic portfolio of EPAs. If you have that portfolio in a lifetime, it doesn't matter if you lose EPAs because you don't practice. And it would be great if you could add EPAs. So that is the whole EPA story in general terms. And you could see that when we started working with EPAs, only a few instances, people picked it up and suddenly it really took up. Now, there's many countries in the world that start using EPAs. There's much in the literature. And I won't do this very extensively, but you could see in almost all specialties, EPAs are being used in postgraduate training. My country actually has really started using EPAs from January 2019 on. All programs will start using EPAs in postgraduate training, and undergraduate training is using more and more too. So this is my last slide. There's many references. You're free to have this slide, so you could look up the reference if you want to. And I just want to mention that we offer an international course for medical educators, and we'll have 3 versions of that course in 2019. Thank you very much. Just within the time.
Muy buenas tardes. Bueno, ya casi tardes tengan todos ustedes. Agradezco mucho al doctor Germán Fajardo Dolci, director de esta Facultad de Medicina, el que haya invitado a la Academia Nacional de Educación Médica, que en este momento está representada por mi persona, a participar en este evento, en este congreso tan interesante, y también en especial a la doctora Liz Jamuy, quien también ha estado viendo desde hace muchos años los aspectos importantes de lo que es la educación y la investigación educativa. Para mí, doctor, es un placer estar aquí con usted, una de las personas más importantes en el ámbito de estos nuevos aspectos de incluir las actividades profesionales confiables dentro de las currículas de los médicos, no solo a nivel de lo que es pregrado, sino también a nivel de lo que es posgrado, que resulta siempre un tanto cuanto difícil. Haré algunos comentarios respecto a la ponencia del doctor Cate, y de una forma o de otra se relacionan con la conferencia previa de la doctora Liz Jamuy. Las actividades profesionales confiables es un nuevo concepto, como ya vimos. Están apenas desarrollándose en los primeros años del año 2000, en 2003, 2005 aproximadamente, en este largo y complejo proceso de lo que es la educación médica. Y sabemos que surgen realmente como una necesidad de disminuir la distancia que separa el aprendizaje basado en la adquisición de competencias y el adecuado desempeño clínico que queremos que nuestros estudiantes, tanto de pregrado como de posgrado, se desarrollen y tengan realmente un éxito en su desarrollo. Se pueden considerar como las responsabilidades o actividades que deben realizar los médicos con los pacientes en una forma segura, eficiente, efectiva, resolutiva y con calidad. Para lograr lo anterior, el médico debe de ser un profesional competente, con conocimientos, habilidades, actitudes que a veces en la actualidad este punto ya ha ido mermando en las diferentes generaciones, y que con todo esto le lleven y ayuden a llevar a cabo actividades profesionales confiables. Además, debe de desarrollar un pensamiento crítico, analítico, que lo lleve a tomar decisiones adecuadas en su momento en un marco inter y multidisciplinario que están definidos por los diversos actores que participan en el proceso de la atención de la salud del paciente. Y muchas veces esto nos pasa en las escuelas de medicina, en que a veces la interacción con otras disciplinas viene siendo cuando empezamos una rotación por un hospital, pero a veces nada más vamos, tomamos la clase, no sabemos qué es lo que pasa al interior de lo que es el consultorio, de lo que es el devenir diario, de lo que es los pacientes hospitalizados, lo que es las urgencias y cómo interactúan y cómo coadyuvan todos estos equipos de trabajo a poder participar y llevar a un buen resultado en el manejo integral de los pacientes. Y también una de las cosas que se menciona es cómo se interactúa con la familia, cómo se interactúa en el entorno, porque no solamente es aquel paciente que llega con un apéndice, sino que es un paciente que llega con un apéndice, pero que a lo mejor no tiene dinero, que a lo mejor ya viene complicada, o que viene, sobre todo aquí en la Ciudad de México, las distancias son terribles, y que viene, por ejemplo, de lo que son el Estado de México o Ciudad de Nezahualcóyotl, que para trasladarse a un hospital hace más de 1 hora, más de 2 horas, y vienen con mucha presión, y cómo es que todo este equipo de salud que ya está entrenado en estas nuevas formas de manejo de los pacientes puede y debe de saber interactuar. ¿En base a qué? Pues en base a una comunicación, a un profesionalismo y sobre todo a un trabajo en equipo, donde como siempre se debe de demostrar un liderazgo y que pues siempre se ha considerado que nosotros, el personal médico, debe de tener un liderazgo, pero también ese liderazgo debe de ser capaz de interactuar y de ver también qué limitaciones se tienen, y con esta nueva propuesta de actividades profesionales confiables y el manejo en equipo es lo que hace factible que se llegue a buen término. Esta visión es holística de la atención de salud de los pacientes y solo se puede obtener si logramos que participen diversas disciplinas y profesiones y que puedan ser realmente todos guiados con un fin común. He aquí entonces que uno de los grandes retos que se presentan con este modelo de atención de la salud centrado únicamente en el médico y que ubica a los otros factores en un segundo o en un tercer plano, pues debe de evolucionar, y esta actividad profesional confiable es la que nos proporciona estos elementos para poder interactuar en una forma visionaria, resolutiva y con calidad. Me dio mucho gusto también que aquí la Facultad de Medicina, pues este modelo se haya empezado a hacer, pues realmente tenemos que son 7 años de distancia en que países tan evolucionados, europeos, en Estados Unidos, etcétera, y aquí se haya evolucionado a poderlo hacer a nivel también de lo que es pregrado. Si bien, por otra parte, tenemos que ver qué recursos tendremos en las instituciones, no solamente educativas, sino también en las instituciones de salud, ya que nuestro modelo de salud es completamente diferente al que existe en otros países. ¿Cómo podemos incidir para que esto se lleve a efecto, sobre todo en otros niveles de posgrado? Sí, hay que fortalecer la formación de los médicos y de los médicos que estamos a veces en las trincheras y que tenemos que cambiar nuestra forma de pensar y nuestra forma de interactuar. Pero también si ya se está haciendo desde la Facultad de Medicina, en el cual el modelo está cambiando para que los médicos cuando concluyan sean médicos generales que tengan todas estas aptitudes y todas estas formas nuevas de interactuar, vamos avanzando poco a poco. Y los profesionales, los docentes, estamos comprometidos con participar en forma activa. Por lo anterior, debemos de impulsar la investigación, y tenemos muchas investigaciones, muchas referencias, y los tenemos como siempre en otros idiomas, en otros países. Qué bueno aquí que ya también estamos haciendo, pero debemos de ser partícipes. Tenemos que desarrollar modelos educativos que busquen el desarrollo de actividades profesionales confiables, con la participación de todo el equipo de salud. Este modelo proporciona la reflexión de la práctica. El profesor es la pieza clave para orientar, supervisar, potenciar y retroalimentar al estudiante, cosa que a veces ya hemos olvidado. Y también el fortalecimiento y el acercamiento en la comunicación a todos los niveles. Por otra parte, otra de las cosas que también hemos olvidado a veces por el gran número de personas que se forman es que todos tenemos diferentes tiempos y formas de aprender. Con este modelo y el acercamiento nos hace que podamos ir llevando a nuestros alumnos a diferente paso, y la flexibilidad, esto es lo que nos va y nos ayudaría realmente a tener mejores profesionales de la salud. Por lo cual, definitivamente, nos debemos de comprometer a este cambio, a participar en este proceso de educación médica con el objetivo de mejorar la calidad de la atención en salud de nuestros pacientes en este siglo XXI, y que tengamos, como en algún momento esbozó el doctor, una satisfacción dada en una sonrisa, pero no solamente del paciente, sino de nuestros alumnos, de nuestros profesores y de todo el equipo de salud. Y agradezco nuevamente y me congratulo el conocerlo, doctor, y el estar aquí en mi querida Facultad de Medicina. Muchas gracias.